various sorts of uh, copied and pasted stuff. You can still, oh, it's okay to copy and paste, but still convert that into Times New Roman, size 12, 1.5 spacing, so that we can read. And as as a homage to whoever you are copying it from, say, most of you will be copying from some other authors, no? So it's best to give them credit because it's okay to copy, but we would actually prefer whatever is in your words. Actually, uh, only quite a few topics can be copied and pasted. The rest of the thing is around your own case. So, so that's why all the figures and tables must be numbered and source credited in italics. So that's how to do it in in scientific literature. So and submission should comprise of candidate's own writing. That is what we prefer. So, but if you don't really have time, you can get something and paraphrase it and put. But it is really nice to uh, have something written by you all because then it's beneficial to you because this is the only practical thing that we do. So, is there any questions on this? Has anybody started doing? Hello.
Hello.
Yeah, go on.
No, no, sir, I haven't yet started. I am going to start from tomorrow.
Yeah, don't wait till the last moment. This is not a big thing. See, we haven't even specified a word count, no. So anyway, so introduction to the case is just like any other case introduction that you all have done in the med school. So uh, what kind of a patient you should actually should not put the real name, no. So the patient X so many years comorbidities and also on and so on. So just a summary of the patient. And then wound biology you will learn today. So use that jargon and explain what's happening in this particular patient. Do you get what I mean? If it's a venous ulcer, what's wrong with the patient? What the how his derangements uh, causes the rearrangements in the physiology and anatomy. So how the wound came forth and what's the cause for chronicity? What is the analysis of that? So actually, you cannot copy it from anywhere. Maybe you can get some pictures and stuff. It's good to have illustrations. I mean, you don't have time to produce your own illustrations, so get something copied and get it in place in with your writing. So now you will be learning general wound biology at 10 o'clock today, 10:30. So we need that analysis, that jargon in this question, in your or own case. So uh, then uh, what you did to the wound bed, apply the time principle. Just take the time principle, TIM. How you did the tissue uh, management, how you manage the infection, whether there was infection or not, how did you decide whether how did you diagnose if there is and was an infection. So how did you balance out the moisture, and how did you support the epithelial edge? And were there any problems identified? And when you were doing it, did you encounter any particular issues? So that's what we want to hear in wound bed preparation. Resin selection is basically your thinking process behind the choice of your resin. It might be a single resin, say acetic acid, every third or fourth day for so many cycles, or different resins. Can be acetic acid, then converted into Vaseline goes and some gel. So each point, what's the rationale? Not a lengthy essay, just how you came to think of it. You all get what I mean? Basically, we are asking you to apply what you learn in the lectures. Anybody actually has started doing anything on this? So then we go on to discuss overall management of the patient. So how you corrected, say, what were the problem? What's the problem list? I would put up a problem list identified from the introduction. The problem list of the patient, say maybe anemia, and even the social issues and economical issues. Those also come. Then how did you address each one of them? So this will be quite lengthy. So I mean, if each and every patient has about 3 to 5, maybe 10 problems. So if you haven't identified any problems, then like it seems that you haven't done it like. So at least try to explain quite a few problems, maybe 3 to 5 problems, and apply your knowledge. So basically, this is something like a reflective thing. What you learned, you reflect that on your practice. We want to hear what you did. Then the outcome as of now. So in the introduction, it's better to introduce to include some pictures, clear pictures, and you can even include pictures of your patient, no, not the patient, the wound. If it's necessary in the wound biology and wound bed preparation as well, it's good to have pre and post wound bed preparation photos. That will be fantastic. So outcome as of now is basically a clear picture would explain thousands of words. And what measures you took for wound prevention. Then you go on to discuss what were the measures. Now you learned wound prevention, and there's so many aspects of it: primary, secondary, tertiary. So then what were the necessities in this patient, and what level of prevention are we aiming for, and what did you do to make sure that the wound doesn't recur? Can be advisors, can be footwear, can be all. Can be a review plan as well. Then what are the barriers and difficulties encountered during the management, during this whole process? What were the systemic and other outside barriers? And what were the barriers within you? And what were the uh, uh, difficulties with the, say, pertaining to the patient? When you try to execute what we have already originally planned for. So it can be the patient's inability to come routinely, maybe uh, the patient cannot afford the proper dressing, or can be something, say, the patient face some natural disaster, like there are so much rain last few months. So maybe something like that, something outside. If that you cannot do anything, that is also a barrier and difficulty. Yeah. So those you can, if you have it's good to have sort of a structured table, outside barriers, the patient factors, maybe within the, uh, say, the practitioner and all that. So then you have a list that I think that should sort it out, short and sweet. But it's always good to explain a little bit, and then you will understand. And a brief discussion on what you did and opposed to what others are doing in the international literature, what is available in the international literature, and for this kind of a wound. So very simple discussion. This would have been my uh, this is what others have done, and this is the outcome that they have got, and I am not far behind, though I didn't get it because of the difficulties and barriers I encountered. And there are maybe my initial diagnosis was wrong. I had to go back and reassess, and that sort of a discussion. And then you go on for recommendations. Recommendations can be very bold, like maybe changing the president of Sri Lanka so that someone will bring free dressings and all that, and will supply everybody. So that can be a recommendation. That's okay. It can be very hairy and bold, but definitely related to your case. There should be a logical connection. And in the introduction to the case, we would prefer if you describe the uh, patient, then in another separate paragraph, the wound, the way we have, I think in the first lecture, we gave a little bit of a 10-piece sort of assessment. So in those topics, so that it will be easy. That's what we actually expect. You all to at the end of the certificate to look at and assess, and that's to get to a verbal diagnosis. So at the end of the discussion on wound biology, I think you should give a probable diagnosis, and then go on that diagnosis. You should go on doing the wound bed preparation and the dressing selection. So that is your basic reasoning for your bed preparation technique and dressing selection. Then plus overall management to support it. Then with that short-term management outcome as of now. If you want to revisit your diagnosis, you can say that in the discussion. So then if you actually had to revisit, then you should analyze the barriers and difficulties encountered getting into the correct thing, and what made you stray around not getting a proper diagnosis also. So that's basically what we expect. Any questions on the assignment?
So that WhatsApp, the format which you have sent on the WhatsApp can't download because it's no longer
I
available.
see.
Can you resend it?
Yeah, wait. Right, I'm sending it now to WhatsApp.
Yes.
Is
It's in docx format. That's the problem. Okay, I'll put into the chat as well. As I can't send it to the chat because it's in use. Yeah. Has anybody tried opening the document I just sent in WhatsApp?
we can open.
Yes.
You can, right? So, okay, I'm putting the copy to the chat. Okay. So just fill in the blanks. Hasn't anybody at least filled the first page? I mean, that's the first thing to do. You have 2 weeks from now, and we'll be finishing collecting the assignments on the next Tuesday, the Tuesday after. So that is 10th. So that's the deadline. Those who have submitted the assignment on 10th. So we'll get the probably you all will get the confirmation on 24th. We need about 2 weeks to look at it, and then within about a week, we will put up the confirmed list in WhatsApp, and then if there are any discussions or whatever that can be done through the WhatsApp, and then or email, then we would be able to mail the certificates probably on 1st of October. If everybody did well, even before that. So do you all think you all can finish it? It's not a big thing.
So excuse me. Hello, sir. This is
Yeah.
Dr. Niroja from DH Katrevelli. Actually, sir, currently I am in the middle level management program at NIH, National Institute of Health Services. My program will be finished on the 6th of September, sir. So I think I unable to finish it the before on 10th. So can you take my time for at least for afterwards 1 or 2 weeks, please?
Yeah, the thing is that then everybody will get delayed. No, if we postpone the date, what we I think let's discuss in the with the council as well. I think they would also agree to this, that let's have the date fixed to 10th, and can you please write just a simple this thing stating your grievance, then we will allow it, and then you can submit maybe now your 6th is your problem, no? Until
Yes, sir.
6th
Actually, I have the class till
September.
6th, sir. Yeah, 6th of
6th
September,
of
sir.
September.
Yeah,
Yeah,
it
so
finishes on 7th.
so 7th, so you can attend to it from at least from 8th, is it?
Sir. Yes, sir.
Yeah, so so then you should ask 2 weeks from 8th. So that's finishing on 22nd. So just ask for 2 weeks from 8th, and then
Yeah, okay.
you will receive it separately. I mean, quite later. I think that's otherwise everybody gets delayed. No, isn't that so? Otherwise,
Okay, sir. Thank you, sir.
that's a good, that's fair, no?
Yes, okay. Thank you, sir.
Anyway, I mean, I'm not just deciding here. I'll ask Madam President as well. Just drop in a mail. I think you have the. Do you have the college email?
Yes, sir. Yes, sir.
Yeah. Okay. Then, yeah. You just.
No,
put a
sir. I don't
mail.
have your Gmail, sir. Actually, I have all the written documents, but can you send it via the
Wait.
WhatsApp or the Gmail is?
Yeah, I'll put it to the. Chitira, are you in a position to put the college email faster than me? Or Dr. Ishanka?
Yes, Tusita.
I will put in the WhatsApp group.
Are you putting it in the WhatsApp group? Okay. Anyway, let me try. I have put the email address. So yeah, if there are any grievances, you can write to it, but don't, you know, don't do it unnecessarily because everybody will get delayed otherwise. Just finish it off in another 2 weeks and then you can get the certificate in another week. So I think that should be your that should be everybody's target right now. You know, since you have now today are finishing, so there are no point in waiting for another month or two to get the certificate. No. Any other questions? What about the things that you have done so far?
Hello. Hello.
Hello. I'm
Hello,
here.
sir. Sir, I have a question. Do we actually have to follow up a patient or just to take a patient and do our own management?
Yeah, it's not very practical for everybody, no. So just
Yeah.
take some sort of a wound, a chronic
Okay.
wound,
Okay.
and yeah, and then analyze it. I mean, you to do say you can do the introduction, you can do wound biology,
Yeah.
you can do around it. Wound bed preparation, if you can do it, that's good. But just write down what you would have done
Okay.
to that patient if it's not your patient. So
Yeah.
uh, And you can actually discuss with the primary caretaker as well, what he's doing up here, primary physician or surgeon as well, what he's doing and what is his this thing, and you will learn
Okay.
what the thought process. Then the dressing selection, but say when you are discussing, you can discuss. I mean, if now not everybody is well versed in wound management, so you have a basic understanding now. You can use the jargon, say have a scientific discussion. So why didn't you do
Okay.
this rather than this? Is this the case? So isn't this the correct way of doing it here? Like it's not getting challenged and all that you can discuss as well, and you will learn something. So
Okay.
that sort of a thing. Then the disinfection also you can go on that and what you would have done. Overall management, basically you can work around what has happened.
Okay.
So how you would have managed versus this thing. Or you can state this is you took the case from someone from a surgical ward or something. Don't go into specific details about whose patients and all that. Then you
Yeah.
can have a sort of a the discussion in your assignment. That the overall management is such, but this is what happened, and then outcome is now. But so wound prevention, these are the things that should have been done. And say in the discussion, you can say that this is working, the management is working well, it's healing, or it has really gone bad, or it's a stalemate. You have to go back to the drawing board and rediscuss, reassess, and all that. So that
Okay.
it's up to anyway. What we need is basically for you all to use what you learned, discuss it in relation to a patient and a wound.
Okay.
But I mean, don't take a common photograph. Do it if you are really in trouble. But I mean, there are enough chronic wounds in Sri Lanka. There are 1 lakh of chronic wounds right now to be seen. Everybody is seeing about maybe 300 to maybe 500 cases per day. So the rest of it is there, yeah, out in the wild. So you can find a case. So anyway, those who have asked me, I will send some pictures and with a brief case history, but not a detailed one, just to what it is. So they can work around that.
Okay. Thank you, sir.
Yeah, Dr. Tushani is here. So today the first lecture will be on bed sores and management and prevention of it. I think prevention we spoke in a little bit of detail in wound prevention lecture, and then afterwards the wound biology thing. So it's So both lectures are very important. I know it's quite late in the day, but try to focus and get the most out of these. So I'll stop sharing. Is there anything that you all want to share with us? Any experiences, good or bad? Okay, I think Tushan is ready to do the lecture. So all that thought. So over to you, Tushan.
Hi, thanks. Sorry, apologies for getting late, everybody. I hope my slides are clear and you can hear me.
We can hear you loud and clear.
Okay.
You're not on full screen. Yeah, now it's okay.
Okay. Right.
Can
So I think today's it's not a it's an important topic, but it's also a topic that that crosses lot of it crosses certain topics we've already discussed, like Dr. Tosin says. So it's useful to try and recap what we've done also, because it's about biology, it's about pathology, it's about dressings. A lot of things are involved when you talk about pressure ulcer and management of it. So I'll just give overview of things, and if anybody wants to have a chat and ask some questions, you can do that as well. And most of these are things that you know about, but I just try and give some principles and some basics, so you will perhaps find it useful to think of those things when you manage a patient with a pressure ulcer. Now, when you say pressure ulcer, a lot of people have different opinions. We call it bed sores, decubitus ulcers. Which ones are we talking about? It can be sometimes misleading when you say pressure ulcers to various different types of ulcers. Obviously, there should be an injury to the skin or underlying tissue. And this is due to a prolonged pressure on that skin. Now, this often happens in areas where there is going to be pressure on when the patient is lying or sitting or in whatever position. So you also got to remember that the site of this ulcer will change based on various things. What is required is in whatever position the patient stays for a long time, they're staying in one place for a long time, that skin of that area is going to be traumatized. And if there's injury to that skin and the underlying tissue, there will be a pressure ulcer. So when you talk about why it happens, it often happens over bony prominence, because if there's soft tissue only, it can accommodate pressure. Where it can't accommodate pressure is when there's a bone or something like a hard structure. And then what happens is the tissue between the bone and the skin is going to get squashed, and that pressure, that is prolonged pressure on that area, will lead to tissue injury. Sometimes it's not only pressure directly, it's also what is called shear force, where because of tangential pressure or pressure horizontally can actually lead to shear force. This often happens with friction. So again, something to be mindful about. We often feel that pressure ulcers happen because of prolonged pressure and lying in one position. No, most of the data I'm putting on and what information I'm talking about is based on guidelines that's been issued by the NTUAP. There are various different types of classifications and descriptions, but I found this one particularly useful. So what we got to remember is that at any given point, these soft tissue over bony prominences will have various risk factors. Its pressures and various things act on these areas. Now, we all have a certain capillary pressure. Vessels are there. Blood vessels become arterioles, they break down into capillaries, and the capillaries leak fluid out into the interstitial space. And if the pressure that is exerted on that area is higher than the capillary pressure, then that's going to cause problems. It reduces to reduced tissue perfusion and ultimately ischemic necrosis of tissue, subcutaneous tissue, skin, and that will lead to a pressure sore. Now, like I said, you remember that there are different types of pressures. The constant pressure, as we talked about, is due to the constant pressure. And that happens because the patient is lying in one position or staying in one position for a prolonged period of time. And therefore, that ischemic pressure, and the pressure that is more than the capillary perfusion pressure, is being staying for a long period of time, leading to reduced blood flow to the tissues. Must also remember that there are different types of other forces, and one is friction. Now, friction happens when the skin rubs against the clothing or bedding. And if it rubs against it, and somebody, for example, rubs very hard, rubs vigorously, that will lead to a type of pressure ulcer as well. Is more often in people with fragile skin. So the elderly people who are dehydrated, or there's a lot of maceration on the other extreme, or who are poor nutrition, and a lot of skin folds are there, they are at risk of friction injuries. The third type is called shear injury. Shear injury happens when the two surfaces are moving in opposite direction. For example, if the patient is, let's say, propped up, we keep the patient propped up because the patient needs to be, to help mobility, to help vision, to see around, we keep the patient propped up. But if you don't do it properly, sometimes the patient continues to slide down slowly. And as it slides down, the skin and the bed surface, they move tangentially in opposite direction. And that leads to a shear injury. So we often forget that these two different types of injury forces are also involved in pressure ulcer formation. So skin blistering, skin being ruptured by external pressure. When you hold the skin, you move the patient, transferring from one person to another place. The way you keep the patient fixed, how you position the patient, how you keep in the right way so the patient doesn't slide down. These are all important when you think of pressure ulcer formation. Now, normally, all of us, if we have injured to tissue, we will have a response and a feedback response that will make us want to move the way we are. If there's a lot of pressure, if we start getting some pain, we move around. Now, this problem happens, therefore, in people who would not have that feedback response or who can't respond to that stimulation. So, that is also very important to realize because we are not looking at normal people like diabetic people or with people with other comorbidities. It's not just the comorbid profile. It's not just diabetes. It's also people with impaired sensation, impaired mobility, and sometimes impaired mental status. And for these people with that prolonged pressure, they do not change their body position. They continue to be that same way. So this is important to figure out when you manage this patient that you can't just sort the wound out only. You need to look at this in a more holistic, global picture. Moisture and dryness that is too much is the bad thing. Excess moisture is also bad. Because excess moisture means the skin becomes macerated. And therefore, the skin folds are different and the tissue becomes edematous. And that skin is also at high risk of breakdown. Again, something to think about. How do you get excess moisture? By various methods. It could be urine that is passed with these people. Sometimes they wear pampers. These pampers aren't changed for a long time. It could be motions. So stools can cause a liquid formation. Sometimes they have diarrhea, and that can lead to prolonged maceration. Sometimes nothing of that is just a sweat. Patient lying in the same place for a long time, sweat builds up, and that maceration can also cause skin breakdown. So again, these are important things to think of when you manage this patient. You got to look at all these things. Essentially, if this unrelieved pressure is more than the arterial capillary pressure, is normally about 25 to 30. If it's more than that and it's sustained, you're going to have a problem. It will disrupt our blood supply, it will prevent oxygen from traveling, and therefore, no nutrients, no oxygen is going to get a ischemic wound. So again, you got to remember this would happen in normal people. There are a lot of risk factors that would predispose to the people to getting this problem. It tends to be commonly prolonged immobility. People who are not mobile. It could be a stroke, spinal cord injury, paraplegic, debilitated, dementic, old people. Of course, at the same time, comorbid profile is important because that will predispose them to a higher risk. Yeah, diabetes, smoking, impairs the blood supply. Think of systemic issues. The fact that systemically this gentleman or this patient is at a higher risk. The nutrition, your glycemic control, your albumin levels, your anemia, hemoglobin levels. There might be vascular fats. The immunity might not be strong enough to mount a response to the infection. So all these risk factors need to be looked into, thought about, when you think of how a wound can happen and how we are going to prevent it from happening and how we're going to treat this as well. Now, again, just think about the fact that we often feel we know some classic sites of where this happens. When you see the pressure, when you see a pressure ulcer, you can figure out where the most common posture this patient will will be staying in. If the patient is lying down, I mark the common areas where you are at a higher risk of getting pressure ulcers. The back of the head, the shoulders, elbows, the sacral area, heel pad. It is turned to one side, the hip area, the greater over the greater trochanter. If the knees are jutting together on the inner side of the knee, and these are all sites where bones are there. And with bones, there's ligaments, tendons, and a lot of other non-healthy tissues as well, which are easily damaged and can expose the joints as well, or the underlying bones. So they are at risk of osteomyelitis, sometimes septic arthritis, sometimes tissue gets infected, they can cause necrosis fasciitis. A lot of things can happen. But this area, these sites of a person who's lying down or sleeping for most of the day. If he's staying prone, if he's staying on a side, if the patient is on a wheelchair, on a reclining bed, the sites are different. So you can figure out based on where the pressure ulcers are, what the most likely posture of the patient is, and what you need to change to try and get the pressure off those areas. But whatever you do, whatever way you try and avoid it, what happens is you will end up transferring that location to another new location. So you got to be mindful that as you change the postures, you'll probably have different set of at-risk sites as well. Right. Now, most of the management, right, and how you diagnose and you look at a wound, look at the pressure ulcer, you are trying to get a grading or a staging of the significance or the severity of this problem. How severe is the pressure ulcer? And based on that stage, your management will slightly change. Now, remember, we have different layers of skin. You have the most superficial layer being the epidermis, right? And the topmost of that layer is actually non-viable dead tissue. You have a basement membrane that keeps on producing this dermal skin. And the dermis from underneath. And the hypodermis is also called the subcutaneous layer. Then you have a fascial layer just deep the hypodermis. And under the fascia, you have a lot of other deep structures. The muscle, the bone, the tendons, ligaments, joints, all those tissues. Now, based on how far deep the pressure has been transmitted and how far deep the tissue injury is and how far deep the tissue is damaged or necrosed or exposed, then we stage this ulcer into various categories. If the dermis is not greatly involved, it's a stage 1 disease. It's limited to the epidermis only. If the dermis starts getting involved, then that's a stage 2. If you're seeing subcutaneous fat, blood vessels, or some fat and tissues like that, then there's a stage 3 where it involves the hypodermis. If you're seeing tendons, bones, fascia exposed, underlying ligaments and stuff happening through, then this is stage 4 disease. So as you go along the stage 1 to stage 4, the depth increases, the degree of tissue trauma increases, and the management becomes even more difficult to manage. So again, a very, very straightforward, simple looking like things to sort of figure out, and this is diagram. So you figure out where exactly the problem is. If it's only the dermis, you don't have an ulcer as such. The dermis is intact, right? Dermis is not damaged, but you find the epidermal damage is there, and that leads to erythema. That is non-blanching. Keywords, non-blanching erythema suggests it's a stage 1 disease. And then you know this is at an active spot. If you leave it alone for a long time, you're going to end up damaging the epidermis and involve the dermis. Then it's like a partial thickness burn essentially. And you have an ulcer therefore. If you're seeing fat, the yellow color fat in the base of the foot, then you've gone through a stage 3 disease. If you're seeing tendons, fascia, muscles, joints, bones, then it's a stage 4 ulcer. Right? Now, sometimes, remember, you can't stage this clearly. And we talk it as an unstageable pressure ulcer because there's something over this wound that doesn't allow you to see what's happening underneath. Now, this, for example, you can see different stages of this ulcer around this erythema. So around that black margin of tissue, there's a stage 1 pressure ulcer developing. The erythematous non-blanching skin. The central is necrotic, and it's not very clear as to what is happening underneath. It could be the dermis being involved only, or it could well be the fat being involved as well, or it could be stage 4 ulcer. So definitely, to get this amount of necrosis, you're looking at a stage 3 or stage 4 ulcer. And sometimes we leave it alone to make sure that we don't expose the underlying structures. But if there's infection, we might not see what's going on also. So be careful if you see a pressure ulcer like this as to whether you're missing something, and therefore you land a lot on other things like, is it boggy? So it feels soft underneath. Is there discharge coming around this ulcer? Is the wound smelly? Is the patient looking unwell? Sometimes, if you miss it by a week or so, it could end up being a badly infected pressure ulcer. If you open that and remove this necrotic scab, you might see what's going on, but then you have to manage this as a proper wound as well with proper dressings. Another important thing is this deep tissue pressure injury. Right? So what happens here? This is non-blanching red color appearance that happens. Sometimes it's a blood-filled blister. These again normally happen with pressure as well as with friction and shear injuries. Right? This is probably something that's going to evolve with time and something to must, but it will also end up progressing. You don't look after this patient and lead to a stage 1, 2, 3, 4 ulcer. So in looking at ulcers, just to try and figure out exactly what is going on. Think of the patient as a whole. Remember, there are a lot of systemic and at-risk things that you need to look at in terms of the patient's mobility, his nutrition, immunity, comorbidities that are contributing to this. Think of the sites of where the pressure injury is. Remember, by looking at the site, you can figure out where the problems might be. What is the common posture the patient is in? Is it direct pressure? Is it shear pressure? Is it friction causing all these injuries? And once you see an ulcer, try and figure out what stage this ulcer is. So the different forces are there, causes on pressure, disrupt blood supply, ends up being a pressure ulcer. Moisture is a detrimental thing. It makes it terribly worse to manage. Your internal risk factors need to be looked at. Older people, your comorbid profile, smoking, immunity, dementic people, your nutrition of hemoglobin, albumin, malignancies. And these all need to be managed if you want to solve the pressure ulcer as well. You need to solve the pressure effect, you need to solve the shear forces, you need to solve the friction, maintain moisture, the right balance, not too dry, not too moist, look into the risk factors and modify them to sort this patient out. Right? And if you don't, it will happen. You end up with worsening pressure ulcers. So how I would think of it, you got to think of things in terms of how to plan your management based on the type of ulcer we looked at. So obviously stage 1 ulcers are different, or a stage 1 pressure ulcer, pressure injury. There's no tissue breach as such. It is simply non-blanching erythema. You got to make sure you offload the patient, turning the patient around, air mattress, doing all those things, and apply a protective dressing that will keep the pressure off. Moment you end up having a tissue breach, then you got to think of the principles of wound care and get the wound bed prepared, which we talked about in a couple of weeks back. Need to make sure the nice absorbent material there, absorb the excess moisture, donate fluid if is required, if the wound is very dry, and you figure out what dressings to use. Use a gel dressing, a foam dressing. With too much of exudate, you got to think of things like alginates, which will absorb the excess moisture. Think of how to rest the wound, how frequently rest the wound. That will help you to figure out how you're going to get the right moisture balance and get the most optimum wound bed prepared. Now, this is for people I'm talking about with no necrotic tissue. You have an ulcer and that's it. Now, at some point, you'll realize that this will get infected. Often they do, because it's difficult to manage them. The sweat building up, contamination with urine and feces, right? Poor wound care, poor nutrition, they're systemically unwell, they can't mount an immune response, and therefore infections can happen. An infection often is a local infection, the surrounding erythema, surrounding inflammation, surrounding infection, or it could be deep-seated, extending into the bone, causing osteomyelitis, then tracking along the fascial spaces, causing necrotizing injuries. It can become septic as well. So obviously, you got to look into those things and appropriately give antibiotics. If there is no evidence of infection, there is no requirement to routinely give antibiotics. The dressings alone sometimes are adequate to manage the problem. But if there is local infection, you might want to take swabs, cultures, and try and figure out what antibiotics to give. But that's got to be managed with that systemic, global, holistic management care. Or it's difficult sometimes to figure out about osteomyelitis. It's difficult to do x-rays in these spots. Essentially, at some point, if the wound opens up, you use a glove finger, feel around, and if you're feeling breached or bone and the periosteum is almost touching, the fascial areas or fascial covering are removed, are damaged, you can feel gritty bone, then there's probably going to be osteomyelitis. And this is very difficult to manage in these patients with pressure ulcers. Of course, if they're systemically unwell, think of IV antibiotics. Now, how you manage a wound that has a pressure ulcer, that has necrotic tissue, it's another different strategy. And obviously, people might have different opinions. I would, of course, like to hang on to that necrotic scab for as long as I can. For me, that is probably the most ideal dressing that I can use on this wound. Like I said earlier, what you do not know is you cannot really grade this wound properly because you do not know what is happening underneath. I would suggest to think of sepsis, look at infection. If you think there's infection, you got to end up removing the necrotic tissue. You cannot think of infection and leave the necrotic scab behind. If you're confident that there's no infection or very minimum infection and there's nothing unhealthy happening underneath it, you could wait and watch and see if it demarcates and if it autolyzes and falls off. So if there is worries, then you perform debridement, and that often tends to be sharp debridement. Patient will need to go under scalpel, remove the necrotic scab, remove the necrotic tissue underneath, see what's happening, and sort things out, clean, and debride it. If it is not essential, I would let the dressings take care of it. And that be using straightforward, simple dressings like even normal saline, some autolytic debridement. It will keep on desloughing, it will keep on demarcating, it will keep on peeling off, and if you're lucky, it will fall off. If the wound is exposed, then you get to this left side slide I showed you, the left side of the slide, where it's a stage 3 or stage 4, where the necrotic tissue has been removed. And then you keep on using the appropriate dressings to try and maintain an optimum wound bed preparation wound bed. So this is the management of the pressure ulcer itself. Again, don't forget, it is not only the pressure ulcer. We talked about this in wound care. You got to think of the holistic plan as well. How you avoid all of these things. How you need to avoid these pressure forces. How we avoid the shear forces. How we avoid the friction injuries. How we therefore turn the patient from side to side. What mattresses do you use? Can you keep on an air mattress if you can? Can you change the posture of the patient? Can you make sure you don't lift the patient or you don't drag the patient across the bed sheets? The patient is positioned the proper way. Patient doesn't get dragged down. That's called the bench position. How you manage the moisture, how you manage the risk factors, and make sure that these contributors are all sorted out as you look after the wound, the ulcer, the wound bed, and the use of antibiotics. End of the day, it's about trying preventing all of these things. And essentially, we have already talked about all these things. If you want to prevent, you look at the basis of how things happen, the pathology and the basics physiology of how things happen. We know how the pressure ulcers happen. We know what pressure forces are there. We have to make sure that these are not exerted on a patient. Which patient are we talking about? The patient who is at risk of getting pressure ulcers. And we remember the internal risk factors that these people might have. Essentially, those who are having immobility and prolonged rest. Tends to be those who have spinal cord injuries, paraplegics, who have strokes, who are debilitated, who are demented, who have mental illnesses, who are having cancer. These are all those risk factors. Right? Think how the skin is. If you have such a patient, how do you prevent it? You got to make sure you look carefully at each and every single visit. If you are a carer who looks out such a patient, look for that stage 1 ulcer happening. Look for that non-blanching erythema. If you see that non-blanching erythema, you know something is going wrong. You got to change things around, a different position, a different posture, maybe find a different way of offloading it, a different mattress, more on a wheelchair rather than a bed. Minimize the pressures. Minimize the pressure that is direct pressure, minimize the shear pressure, minimize friction. Maintain the adequate moisture, and that requires sometimes a catheter, for example, sometimes changing and diverting stools, for example, the colostomy, sometimes requires use of Pampers that is judiciously used. You want the patient lying on a mattress and the urine continues to flow and the entire mattress is therefore full of urine. You want to use something like Pamper, but those also need to be removed and changed often. Think of things like talcum powder, moisturizing cream to maintain the moisture and the quality of the skin. You got to have a patient who is healthy, who's got good nutrition. That is essentially your macronutrients, water, proteins, the cholesterol levels, and also think of the micronutrients also. So good hemoglobin, a good albumin, good urine output, it's a good patient. So if you do by some chance see, you got to try and make sure you prevent the ulcer from going from one stage to the other stage. So at each stage, make sure you don't get to stage 1. If you're at stage 1, make sure you treat it and don't go to stage 2. If you're at stage 2, you treat it and make sure you don't go to stage 3. In stage 3, prevent it from going to stage 4. So I hope I gave some information. And what I want to do was to give the basics of how this happen, so you can figure out when you see your patient how you best modify and adapt their situation. Again, I don't want to promote drugs or material, for example, but it could be finding the most appropriate type of bedding, appropriate type of mattress, appropriate type of nutrition, appropriate dressings, appropriate skin care, wound care, to make sure you don't get things worse. So thank you. I hope the message was clear. And again, anybody wants to ask questions or clarify something, please do. But I hope the principles and the understanding is there so you can adapt and manage pressure ulcers in any way you want. Dr. Tushar, I'll hand it to you.
Yeah, Roshan, thank you very much.
Questions? That's okay.
Any questions on this?
So what are the ways that we can maintain the moisture? I mean, like if it is more, if we want to reduce the moisture, what actions we can take?
Yeah, thanks for asking the question. I'm just trying to clarify. Do you mean for a patient who has an ulcer or who's at risk of having an ulcer?
No, for a patient who's already having an ulcer.
Right. Okay. So first of all, must remember that any wound that is basically as a skin breach, it will have some form of exudate. So exudate is normal. What you're worried about is too much of exudate. That happens with two things: inflammation or infection. So if the inflammation is too much, there's going to be a lot of exudate. If the infection is going to happen, that will cause a lot of exudate. If you're trying to manage the exudate alone with a dressing, to asking, then you think of different way of dressing the wound. And then this is where your alginates, your foam dressings, for example, might be useful. Having a secondary layer of dressings like a gauze towel or something on top of the primary dressing. Think of changing the dressing more frequently. It might require more frequent dressings rather than giving for days and days, because if the moisture is too much, then you got to think of changing the dressing. Whatever you do, there's always going to be some excess exudate. So therefore, how can you look after and prevent the very wound skin from getting damaged? And therefore, you have a lot of things called barrier creams to try and, if you can't stop the exudate from happening, at least prevent it from damaging the skin. Often things like Sudex cream or zinc oxide or these burn creams, you can apply them around the skin to try and reduce the effects of the exudate. How about the posture? If the patient is lying in a way, well, it's like sometimes if the patient is lying for a long time, that bed, it sort of gets a small bend, like a curve, and all the fluid tends to collect there. What about sweat? How can you reduce the sweat? How can you prevent, make sure the patient is getting ventilated, aerated? I mean, so I think it's not one answer. Use various things to try and sort it out. But think of why it might be happening. First of all, are you doing anything to cause inflammation? And that is because of increased pressure. So reduce the pressure first of all, and that will reduce the exudate. If it's infection, you got to sort the infection out as well. If you're trying to sort the exudate with dressings, there are different types of dressings you can use that will have super absorbent capabilities rather than using standard dressings. Think of dressing frequency, and also think about how to minimize the damage of that exudate on the wound and the skin. Is that okay?
Yes, thank you. Yeah, I got it, sir.
Okay.
Thank you.
Excellent. Thanks.
Any more questions? I mean, yeah, we have to move to the other lecture as well. Are there any questions? Any more questions?
Feel free to let Tushar know, and Dr. Tushar will, I'm sure, hand over to me, and then I can always respond back via him. But I think just remember the principles, and then you can figure things out yourself.
Yeah, we are always there for you in that WhatsApp group, and you can contact us at any point. So, Tushan, I'm sure it was a hectic day for you. So, thank you very much for doing this
Sorry for getting
fantastic
slightly late.
lecture. So, now the next lecture is on wound biology from Dr. Ranga Pereira. He's here, and you all have met him, and you know his credentials. And without further ado, I would invite him to do his lecture on wound biology. It's a very important lecture, another one. So over to you, Dr. Rangapirra.
Thank you, Tusita. Can you all hear me?
Yeah, quite well.
Right. Okay. So I'll share my slides. I think I can share. Can you see the slides?
We can see the slides, but you are not full screen.
Full screen. Yeah. Okay. I put full screen. Right.
Yeah, now it's clear.
Okay. Now I'll be speaking about wound biology. So that means what makes the wound be there, and what are the factors affecting wound healing? What are the factors making the wound not to be healing? And so the theoretical aspect about wound healing. So first of all, I will tell you what are we going to do. We will introduction of the topic. That's what I did now, and we'll discuss about some definitions. What are the types of wounds, and a little bit of history of how these things were found out by the ancient people and recent scientists and various people, and types of wound, process of wound healing, and phases of complications of wound healing, and factors affecting wound healing, and management of the wound. I am just touching that area. I think you have had a lot of inputs in the past few days about management of wounds. Right. So, in definition, a wound is defined as an injury to a part of the body that involves damage to integrity of tissue of all body structure. So that means a wound is an injured part of a tissue. The tissue has lost its integrity. Right? That's called a wound. Right? So healing is the process of injury to the injury that attempt to restore the normal structure and the function. So it may not be 100% restore the normal structure, but that may be able to repair up to the functional level. It implies disappearance of process of inflammation and replacement by the lost tissue by regeneration or repair. So those are the two main definitions of wound and wound healing. Wound can be defined as an injury to a body part that involves damage to integrity of tissue or structure. Healing is the body's response to injury and attempt to restore the normal structure and function, and it implies the disappearance of inflammation and replacement of the tissue by regeneration or repair. Also is discontinuation of epithelium. So if any epithelial surface has discontinuation, the raw surface under the epithelium is called an ulcer. Right. So we go back to the history. So wound had been there from the beginning of the human life. So there have been wars, there have been injuries, so there will be wounds. So in the ancient text about how they treated wounds, we can find about 1,500 years before Christ, that is in the Egyptian system. And they have used animal grease or animal fat and honey as a topical treatment of wound treatment. And even if you go the Asian history, Sushruta and others, there are a lot of text about wound healing, but this is much before that. Sushruta's time. Sushruta had been there later than this time. Egyptians believe that closing wound preserve the soul. Right? They believe that if you keep a wound open, the soul is lost through that open wound. Right? So in a way that may be true because the wound maybe lead to a sepsis, and sepsis can lead to septic shock, and ultimately patient can die from a small wound. So covering that wound will prevent the infection and restore life. So they have their some concept in that ancient concept. Greeks have discussed about chronic wound and wound healing. And there's called Galen. Galen is the one who had described the features of inflammation and things. And they have made main contribution to wound care. Modern wound treatment has come around somewhere around 1980s, and they are the one who started this factors of wound healing, and extensive studies were done at around 1980s, and they found various growth factors, growth stimulants, tissue factors, cells which are coming to play in wound healing. All these things came around 1980s. Right. So basically we have acute wounds and chronic wounds. Acute wounds, there are open wounds and closed wounds. Right. Closed wounds we can classify into contusions, abrasions, hematoma. Contusions are tissues are damaged and there will be underlying clotting of blood. But blood is accumulated and the external wound is crushed. Abrasions are very superficial injury which has not damaged the epithelium completely. So it's there only a superficial layer of tissue, the epithelium, or the skin is made up of epithelium, which has multiple layers of stratified squamous cells. So once few of these layers have been destroyed, but the underlying basal layer is remaining. So the epithelium is intact, so it is not an ulcer. So that's an aberration. Hematoma is where there is some injury inside the body and blood has collected under the subcutaneous tissue, but there is no direct tissue damage in a hematoma, underlying hematoma. Open wounds are incised wound or cut wounds, lacerated wounds. Those are cracked wounds basically, and crushed wounds. If a heavy weight or something has fallen into, or a blunt accident like road traffic accident can damage tissue by crushing, and that is called a crush wound. And a penetrating wound, this of course a stab injury kind of thing is a penetrating wound. Those are the open acute wounds, so open and closed acute wounds. And what we are interested mostly in this palliative care is the chronic wounds. Chronic wounds are wound that had been there, probably started by an acute wound or started as a tissue loss from the beginning. Maybe due to various reasons. We'll come to those things later. So some of them are due to arterial and venous causes, right? Venous ulcers, arterial ulcers are there. So I think Tushan has spoke what about those areas. And neuropathic ulcers, diabetic ulcers, or pressure ulcers, which you can see in various sites and the shape. All these things will help you to identify these kind of neuropathic ulcers. And sometimes also the chronic wounds are due to vasculitis, in systemic inflammatory problems, vasculitis. Right. So in basic pathophysiology of wound healing involves two main processes. Number one process called regeneration. Regeneration is the lost tissue is replaced by proliferation of parenchymal cells. It results in complete restoration of the organ tissue. So, for example, if a part of liver get damaged, the liver cells will divide and completely heal the liver as it had been there before. Other example, best example is a fractured bone. If a bone gets fractured, the tissues will come together and completely heal the bone as it had been there before. But some tissues cannot be regenerated. So in that case, the tissue is replaced by fibrous tissue. That process is called repair. The healing takes by proliferation of connective tissue elements and resulting in fibrosis and scarring. Say, for example, a muscle or a skin get damaged. The damaged tissue cannot be completely restored. So what they do is the tissue will produce a fibrous connective tissue meshwork, and then that meshwork will contract together and connect the two ends of the healing process, and there will be a scar between the two normal tissues. But liver and kidneys and things like that, nothing like that will happen. The damage will completely heal up without even scarring. Right? Even skin is healed without scarring in neonates or even newborns up to about 2-3 weeks. If you can make an incision on them, the wound is healed completely without any scarring. Tissues will be replaced. So if you get this process of regeneration, some parenchymal cells are short-lived and others have long lifespan, like neural cells, muscle cells, they have long life. Some parenchymal tissues like liver, kidneys, intestine, those have very short life, and when they die, they will replicate and regenerate and replace that tissue. So to maintain this process, the cells have to undergo regulatory control of what we call a cell cycle. So cells will undergo replication and restore their lost tissue. So these cell cycles are controlled by a lot of other factors. Now these are the factors. I don't know whether you need to remember these, but I prefer if you know about wound healing. The learning of the rest of the things will be very easy. So there are epidermal growth factors, fibroblast derived growth factors, platelet derived growth factors, transforming growth factor beta, and an endothelial growth factor. So all these things have different roles, and they all will help the cells to regulate and regenerate and replace the tissue which has lost from the primary injury. Proliferation of organ and cells in the margin of the injured part will come close together, and that will cover that gap. The proliferation of migrate cells is obviously going to differentiate and mature, and they will restore the complete organ. So best example, if you cut a piece of liver and leave the other tissues to be there, so there will be the hematoma, then this hematoma will be replaced by small fibroblasts, and those things will be there, and they will produce these epidermal growth factors, fibroblast growth factors, tissue growth factor beta, and all these platelet growth factors will come there. So the surrounding margin, the lateral side of the wound, the tissues will come to, multiple cells will multiply and proliferate. At the same time, the blood vessels, the connective tissues between the cells, all these things will also come together, form, and ultimately in about 2 weeks' time, there is no scar, completely liver is there as it had been there. Can't even find there was an injury. That's how some tissues heal. But mostly, tissues will heal through this process called repair. Repair is replacement of injured tissue by fibrous tissue, right? Two processes are there. One is granulation tissue formation and contraction of the wound. So first there will be granulation tissue formation, then there will be contraction of the wound. So repair process takes place by participation of mesenchymal cells. Now earlier there was parenchymal cells. Now we have mesenchymal cells. Parenchymal cells are the cells which are the organ functional cells. Mesenchymal cells are the supporting connective tissue cells. Now here what happened is the repair, the healing is done by the process of this mesenchymal cell. So connective tissue cells, fibrocytes, histiocytes, all endothelial cells, macrophages, platelets, they come and connect these two edges of the injured organ, and they will start repair. So there are 3 phases of repair. One is formation of granulation tissue. First phase is called inflammation. So immediately following trauma, there will be blood clot and site of the injury, and the acute inflammatory response will be there, and exudation, plasma of neutrophils and monocytes will appear in that place within 24 hours. Then the next phase is called phase of clearance. So there will be blood clot and the fibroblast, all these things will be there. And second phase is combination of proteolytic enzymes coming from these neutrophils and inflammatory cells will dissolve that dead tissue and dissolve that blood clot in between, and debris are being removed, and there will be gap of tissue. At the same time, this gap is filled by angiogenesis and fibrogenesis. What will happen is when the gap is being engulfed or destroyed by the activities of the neutrophils, at the same time, under that, the angiogenesis process will occur, and there will be some new blood vessels will form underneath, and another connective tissue layer will be formed by the fibroblast, that's called fibrogenesis, and the angiogenesis and fibrogenesis will connect the damage to edge of the tissues and start healing. Now in repair, angiogenesis needs musculoendothelial growth factor, platelet-derived growth factor, tissue transforming growth factor beta. Now all these things are cytokines which will stimulate the angiogenesis part. Angiogenesis means formation of new blood vessels. Third phase is wound contraction. After about 2-3 days, the wound is completely filled by this granulation tissue, following which within next 2-3 weeks time, the myofibroblast will come there and the wound get contracted, and the two edges will come together slowly by this process of fibrous contraction. Right, now if you take this diagrammatic representation, initial phase is the hematoma. There will be hematoma. Can you see my mouse? Put it to a laser. Right. So initial phase, the wound is there. There is blood clot and a scab is formed. And initial neutrophilic phase or the inflammatory phase, there will be inflammatory cells coming in, and they will going into this blood clot, and gradually they will dissolve the blood clot. While the blood clot is being dissolved, the angiogenesis will occur into this clot area. Now there is fibroblasts, neutrophils, as well as new vessels are there. So third phase is the granulation tissue was repaired, done by the fibrous tissue, and the fibrous tissue will contract together and form the scar. Same thing. Right. So when you suture a wound, the purpose will get the edge together as much as possible, so there will be minimal scarring. And you can see nicely where the suture line had been there, and that is also part of injury, and that will also create a small scar. Right. So the epithelial layers, first the basal layer will proliferate and margin the wound covered in the layer by within 24 hours, and the basal cell they migrate and continue to divide. By 5th day, multi-layered new epidermis will form and differentiate into superficial and deep layers. That's how it happens in the inside wound. So primary union, by 3rd day, fibroblast will also arrive at wound area. 5th day, collagen will be formed. For 4 weeks, scar will be scanty cellular and vascular element, and you can only see few fibrous tissue cells and fibers are there. Right. So second phase is healing by secondary intention. Now, what is my secondary intention is there's a loss of tissue in this in-between area, and this whole area should be replaced by granulation tissue. So when that happens, it takes time, and there is a large scar, and scar is contracting at the end. Right. So complications of wound healing. Now these are during the process, various things can happen to a wound. Right. So number one is infection. Now there's a protein-rich substance is there in this blood clot in this area. So very easily the external bacteria can come into the wound and cause infection. So infection occurs, there will be delay in the wound healing. Implantation means if there may be a foreign body. Now these injured tissue, when it happens in acute injury, there can be pieces of glass, dust, dirt, mud, various things can be there in between and cause an implantation. So they might cover that area and later that implantation part can become problematic to the tissue. Sometimes implantation occurs by the tissue itself. They can get implanted inside and that will grow inside the scar. That's called, later they will form a lump-like thing called implantation dermoid. Right? Pigmentation. So scar can get pigmented. Sometimes they get hyperpigmented, sometimes they can get hypopigmented. So there's, depending on the amount of melanocytes coming onto the scar, you can have pigmentation, hyper or hyper. Deficient scar formation. Scar is less than what it should be. Hypertrophied scar. Maybe more scar than what it usually need to be there. And scar can go into something called keloid formation. That means there's larger scar, but that scar is in the margin of the wound. Now, keloid scar is growing. Scar is overgrowing beyond the margin of the wound. And that's called keloid formation. Very rarely, scar tissue can undergo malignant transformation. That's called Marjolian's ulcer. Very commonly occurs following burn scars. They can get a secondary Marjolian ulcer where very ischemic tissue is there because of the previous burn and scar tissue, and that can undergo malignant transformation. That is usually squamous cell carcinoma. Right. So factors affecting wound healing. Basically, we can divide them into local factors and systemic factors. Local factors, local infection, poor blood supply. From the beginning, blood supply is poor due to various reasons. And movement. Now, if you get an injury or a wound over an area of flexures or over a joint in either side of the flexure or extension region, as long as the joint moves, the scar is not going to get formed properly and wound is not going to heal. Exposure to ionizing radiation. So either before or after, when there's wound healing, if you undergo radiation therapy, the wound healing becomes very poor. If there's foreign body implanted inside, there will be infection and continues to have sinus and discharge. That will be a problem of healing. Bone involvement. If there's bone piece in between this area, or there's a bone connected to the external wound causing chronic osteomyelitis, there's difficulty in wound healing. If the wound ulcers have undergone malignant transformation, that will never heal up until you remove that malignancy and treat it properly. So systemic factors, age. Younger the patient, faster the wound healing. Older the patient, delay the wound healing. So very simple. Nutrition. A good balanced nutrition is completely needed to wound healing, especially protein, calorie, and we need vitamin C, vitamin A, zinc, and selenium kind of minerals are especially required for wound healing. But all these things can be achieved if you take a proper balanced diet. Now, if you can remember your basic sciences, wounds are healed by fibrous tissue. Fibrous tissue are basically made up of collagen. Collagen is proline. Proline is basically protein, and proline undergoes a process called cross-linkage. Cross-linkage is by sulfur ions that requires vitamin C as a coenzyme. So you need vitamin C. Zinc is part of the process of wound healing, and selenium is also required. And usually all these things are very important in wound healing. But if you take a balanced diet, the nutrition can be supplemented. Systemic infection. The patient having systemic infection, wound healing becomes poor because all the body healing mechanisms are concentrating on the systemic infection. Uncontrolled diabetic, obviously, right? That will affect all the stages of wound healing, including molecular formation, cellular function, neutrophil function level, from that level to bacterial overgrowth due to high sugar content and immune compromisation. All these things affecting wound healing in diabetes. And poor blood supply and all these things will affect the wound healing. Hematologic abnormalities like vasculitis, like sickle cell anemia, or anything which involve in poor oxygen supply to the tissue level, that will affect the healing of the wound. Chronic diseases, any chronic illness, something like chronic liver cell disease, chronic renal failure, or obstructive airway disease, COPD or COAD, those things are affecting wound healing. That has been shown very effectively. Now, until you heal the systemic illness, you are not going to heal that wound. Right. So, what are these barriers to wound healing? Now, these things are very important. Now, you think that wound, if you treat them with the proper dressing and if you give the proper nutrition and the cleaning of the antibiotics will heal the wound. It's not usually, that's why there are chronic wounds. Now you need to address these basic issues. One factor is the client, that means the patient. That patient need to be treated. So facilitators should be, receptive and planning and already has plans. So they should have a plan. Now we need to identify the client. The barrier is he refused to talk about the future needs, doesn't want to release the finances, unwilling to discuss the expected plans, unable to participate in the planning. So the patient himself is not coming into the discussion of how we are going to heal the wound. They will come and tell you, no, this is my wound, I want you to heal it. And he's not telling you, how much he can eat, how much he can afford with the food, right? Or the dressings, all these things, he's not supportive. And the family, right? So availability of the caregiver and the family involved in planning of the wound healing. So lack of family. Some people have no family, right? And difficult to assess, assessing the family. Sometimes someone is there, sometimes no one is there. No previous relationship with the family. Difficult family circumstances. Family unaware of the need of the patient. So all these things are very difficult. Case managed, that means the doctor who's doing it. Knowledge about planning and about wound healing, those things are difficult. If wound healing is a very slow process in some people. So he has to be patient and be with the patient, be with the rate of the patient's healing, and all these things are very important by the carer. The program, you should understand the program. What are we going to do now? Say, for example, now a wound with chronic osteomyelitis underneath. Now, until you heal the osteomyelitis part, the wound is not going to heal. The first stage is to treat the underlying osteomyelitis. Second stage is to treat the granulation tissue formation over the bone that had been there. Third stage is about covering of the skin. Now, we have to have a plan how I'm going to treat this wound. So, that should be the plan. Now, if you treat with antibiotics and covering of the wound only, it will be there for a short period, but will come back again. And system. Now, that is our healthcare system. Inform the patient and caregiver of future plans and what are we going to do about it. So all these things has to be discussed. Now these are the barriers. Now remember, all these things are very important. Client, family, case manage the program and the system. Little bit about the microbiology. So there are commensals and pathogens. Sometimes the commensals become pathogens, sometimes pathogen become, that's problem with the commensal become the pathogen. So mainly some of these things are, the common cells, what they do is they are good for the wound, right? Example, Streptococcus epidermis, they are promoting wound healing, like pathogens are not coming in, they are there. So we need to find out this, whether the wound is having pathogens or commensal organisms. Pathogenic organisms are forming biofilms, and pathogenic tissue radicals are being formed, and tissue wound healing is becoming poor. So all these things are caused by the pathogenic organisms. Right. So commonest microbes what we are found on our chronic wounds are Pseudomonas, E. coli, Staphylococcus aureus, and Streptococcus pyogenes. Now these are the commonest wound harboring organisms we have, and among them Pseudomonas and E. coli. Pseudomonas are very difficult to treat, and Staph aureus is also difficult to correct. So we have to treat all these. Okay, I think that this lecture would have done a little earlier than this stage, but I think we have gone through it nowadays. Now, any questions you can raise?
Thank you, Dr. Anka. That was a very enlightening lecture. So, yeah, this is a very difficult area to understand. I am sure you all have questions. So, it's time to clear up your mind. Otherwise, when you are writing the assessment, also you will find what's connecting to what. So, please ask the questions. If you don't have any questions, either you understood everything or you didn't understand anything at all. Which is which? Any questions?
It looks like everyone have to understand everything.
Yeah, seems so. Very clever group. You all can come back to us on the WhatsApp group. I will forward those questions to Dr. Ranga Pereira. So be very clear, and so you can read around this as well. This was a very comprehensive lecture, and if you listen to it, I don't think there are not, anything much to read around. So it was very clear and comprehensive, and you can go back to the recording as well.
Yeah,
So
there's one question. How does chronic renal failure affect the poor wound healing? With chronic renal failure, there's lot of factors, because one thing is blood urea itself will increase the tissue damage, and secondly, the renal failure will cause protein loss. So when someone is losing protein, there's not enough protein. Your wound healing depending on your amino acid pool of the body. So the amino acid pool is reflected by the serum albumin level. So when you are losing your albumin, the amino acid pool is not enough for the wound healing part. So wound healing becomes very poor.
okay, it seems no other questions or queries. So shall we call it a day then? They actually this is the last. Yeah. Oh, there's another one. How are we going to manage keloid?
Now, that's a complex area. So we need to find whether the keloid has formed in a keloid forming area like the midline of the chest or things like that. Or patient profile is the patient is usually a keloid forming person. So first thing is when the keloid forms, if that really large keloid, then you have to remove the keloid and close the skin without any tension. So if you need to release some more tissues from surrounding area, we have to release these tissues and suture the wound without any tension. Then second stage is when the wound is starting to heal, you can inject steroid around the wound healing area as the wound is healing. That will prevent the overgrowth of the granulation tissue in the initial phase. If you delay this steroid injection, it will become it will not going to be responding after it is starting to start to healing with scar formation. Sometimes they treat it radiotherapy, sometimes they have pressure dressings and things like that to prevent this. So all these things measures have been done. What I know is some plastic surgeons they do the scar revision, then they inject it with steroids, then do the pressure dressing and regular steroid injection and pressure dressings, and lastly they give radiotherapy also. So all these things have been tried, but not very successful all the time.
Any other queries? Are there any injections other than steroids? Another question.
Sometimes they inject silicone.
Any other questions?
But I have never injected silicone, but only I have injected steroids, but that works.
So a big thanking is due to Dr. Ranga Perera, who joined at this late evening, and that was a fantastic lecture. And he had been with us from the beginning. So I take this chance to thank all of our lecturers, including Dr. Ranga Perera, consultant non-surgeon and senior lecturer, usually the dean of at the Allied Health Faculty of KDU, Dr. Kitsiri Senanayaka, consultant general surgeon and senior lecturer of the medical faculty, Anuradhapura, Dr. Hilary Fernando, consultant neurological surgeon, Dr. Tushan Gunaratna, consultant vascular surgeon and senior lecturer of medical faculty of Colombo, and myself as well. So anyway, and our Madam President for leading all this. And so I now invite Dr. Ishanka Talagala to do the vote of thanks. Ishanka, are you there?
Yes, Tusita. So, y'all can hear me, no?
Yeah.
Yeah, okay, right. So, thank you so much. I would like to express our gratitude on behalf of the President and the Council of College of Palliative Medicine of Sri Lanka to all the resource persons, of course, as Dr. Tusita mentioned, Dr. Ranga, Dr. Tusita, Dr. Tushan, Dr. Kitsiri, and Dr. Hillary as well. So thank you so much for being the resource persons. And of course, I would like to express our thanks to all the participants. Thank you for your active participation, and I hope that you learned very well on wound management. So, of course, as it was discussed earlier, complete your assignment as soon as possible, and upon upon assessment of the assignment that has been submitted, we would be offering you the certificate of completion, successful completion of the course. So I hope you have cleared all the doubts that you had. So thank you so much for joining with us and getting this opportunity to improve your knowledge. So I hope if anyone is interested in joining the college, you please do so. We can share our membership documents also in the WhatsApp group, so that if you're interested, you can join and work towards the improvement of palliative care in the country. So that's all from my side. Dr.
Yeah,
Tusit, if you have any last words to say, I
yeah,
think you
I
can
would like,
go ahead.
if Professor Samad is there, I would like him to add some finishing touches. Professor Samad, are you
Yes.
there?
Yes. So thank you so much. It was a wonderful session. Actually, throughout this year also, I've been participating, and we could see the active participation of most of the doctors who has followed this course, and of course, very big thank to our council members, Dr. Ranga, Dr. Tusita, Dr. Tushan, Dr. Hillary, and Kitsiri. So the last year also they did a wonderful job, and I can see this year very much improvements also, and with your knowledge, even from the lecture side. So congratulations, and I'm sure now College of Palliative Medicine of Sri Lanka, through this kind of courses, now we have trained, given knowledge to now nearly 200 doctors around the country to how to manage wound properly, and awarded certificates. So this will no doubt will improve the quality of life of our patients, and it will contribute to get the proper palliative care in the country, as Dr. Ishanka mentioned. So once again, congratulations, and don't forget about your assignments. We are a little strict about it, and get your assignments done and submit it. So our faculty will mark it, and eventually you will get the very, very valuable certificates from our college. And our annual academic sessions this year will be on 5th of October. So maybe I'm sure we can post our annual academic sessions flyers on your WhatsApp group, and please feel free to join with us in our annual academic sessions. If you have any case scenarios, or still it's open, you can submit your abstract or whatever, but it should relate it to palliative care. But you can attend to our annual academic sessions, which will be on the 5th at Hilton Residence. So the flyer will be uploaded, and there will be another, talk, particularly about the wound care in diabetics management by Dr. Tushan. So you can attend. There will be plenary discussions and symposia. So, and free paper sessions. So please join with us. And this is the only college where the MBBS qualified doctors can join as life members without any further postgraduate qualifications. So take this opportunity and join to the college. Our membership forms also will be uploaded to this group, and I wish you all the best, and thank you so much. Have a good night.
Thank you, Professor Madhi, and thank you very much, all of you.
Thank you.
Thank you.